Welcome to today's Regional Geriatric Rounds. Today, Dr. Shabbir Amanullah will be speaking on cannabinoids in dementia. Dr. Amanullah is currently the Chief of Psychiatry at Woodstock General Hospital in Woodstock, Ontario. He is the President of the Canadian Academy of Geriatric Psychiatry, President of the Oxford County Medical Society, and serves as Chairman of the Indo-Canadian Psychiatric Society. He was previously Vice Chair for the Ontario Medical Association and is the current Psychiatry Programs Chair for Psychiatry Ontario Medical Association. He has won many awards, including the highest award conferred by the Canadian Psychiatric Association, the Distinguished Fellow of the CPA. He was awarded the CAGP National Award for Outstanding Contributions to Geriatric Psychiatry in 2020 and was awarded the Glenn Sawyer Award by the Ontario Medical Association in 2021. Dr. Amanullah has published content in a number of peer-reviewed papers and books, with research interests in the areas of autism in the elderly, ADHD, and cannabinoids in dementia.
So the reason I started doing this work in this area was when I moved to Canada in 2006. I moved to PEI because we wanted a very a rural kind of setting, but yet in the city. And PEI was as urban and rural as it gets in Canada in many ways. So we moved there, and obviously dementia is as prevalent there as it is in any other part of Canada. But the interventions we had were fairly, were really poor in terms of its ability to manage both the behavioral issues of dementia, but also dementia itself, in terms of modifying the illness trajectory and the pathophysiology of dementia. So the problem that I faced was, number one, there really wasn't any evidence. There were one or two case reports here and there for the use of cannabinoids in dementia. And I'll tell you the story as I start presenting. But I started using this in 2008 and did a case series. We published it in 2013 more recently. But we did a lot of extensive work in terms of its role and what kinds of patients to use it in. And I worked with a group in Spain. I had communicated with them in terms of models that they have, animal models. So a lot of what I'm presenting is cumulative data, both from clinical experience and data over the past many years. But I'll also teach you today how it is that things have evolved in terms of how we view dementia. So once again, many thanks for the invitation. I do have a few disclosures to make. I've given lectures on behalf of Otsuka, Lundbeck, Sanovian, Eisai, Janssen. I have been on the ad boards of Eisai, Otsuka, and Lundbeck. A patent I've applied for and grants from the Canadian Medical Foundation. No conflict of interest, except that I love to teach. There is a certain reading list in here, so you will have this for later access as well. Now, we all know dementia is highly prevalent. I mean, it doesn't take much for us to realize that this is becoming a global issue, and that many countries that are financially well off are struggling. You can only imagine the burden of care on countries that really do not have the wealth to support people with dementia. So when you look at the population of people with dementia, that's a staggering number of people. 50 million people worldwide. Now, the problem is not as much that you have this many people, it's just that we don't know what to do with it. I mean, with COVID, we were able to come up with something like a vaccine, but you still have people who believe that there isn't any COVID. They believe that the 5G caused the problem. On the other hand, we have treatments available, but people don't want to use it because we think, well, it's not good. Why? I don't know very much about it. Why don't you read about it? So we are no different from the anti-vaxxers if we do not read about existing data or are inquisitive to really start doing that. And so it's important for us to be curious as human beings. Now, we know that the prevalence will increase to 68% in low and middle income countries by 2050. Now, this is staggering. For Canada to be the leader, and we should be global leaders, we need to be far more proactive, inquisitive, curious, but also willing to experiment. But do all this within an ethical sphere. We have to make sure that we maintain that, because 68% is a phenomenal number, and we should be the ones to be able to guide the way. 20 to 30% of early dementia patients present with significant depressive features earlier on. What do we diagnose them with? Depression. What is it that we are missing? Dementia. So do they have MCI? And so here's part of the problem. We have an issue with how we classify dementias, right? So I will tell you about it and how we have changed in terms of how we view the classification of dementias, but I'll tell you about cannabis. I don't use cannabis, I never have. I hope I never have to use it. But if I do have dementia and it's going to work for me, brilliant. If I have pain and it's the only thing that's going to work for me, brilliant. The issue though is cannabis is not new in terms of an intervention. If you go back many, many thousands of years, the only thing people had were herbs. It's only when we developed mechanisms and methods of distilling these products that we started realizing that, yes, we can isolate the active ingredient, and then I'm going to use that. But before that, it was, I'm having a headache, honey. Well, why don't you go chew that herb over there, right? That was literally what we did. But if you look at it, the original form of cannabis was first discovered in Central Asia 6,000 years ago. It had a lower THC content. And this is very important to know because we are seeing a higher level of psychosis. Now, we don't have data from 6,000 years ago, obviously. But if the THC content was low, you would assume that there would not have been as prevalent a problem with the psychosis in the use of cannabis as we do have now. Now, obviously, you have methamphetamine being mixed into it, and there's lots of other things coming into it. But if you look at it, what was it that it was used for? It was used for pain and cramps. What did we do over the years? We used opiates. Why? Because we thought the endogenous opioid system is what we should be tackling because that's all we knew. And now, lo and behold, we know we have an endocannabinoid system. So that basically means that within our bodies, there is cannabinoid, just like there was opiates. So when people are using cannabinoids, are we seeing that there is a system they're trying to modulate within themselves? Yes. So if you look at the next block in there, it says human beings have developed a very complex endocannabinoid system, and it has become infinitely more complex. And it's true. This system is involved in energy metabolism, in gonadal function, neuroplasticity, and others. We never knew this. We never knew this. I've lectured on this topic now for the last almost a decade. Very few people are aware of the incredible role of the endocannabinoids in the human body. Many people don't know. And it plays a role in just these that I've listed, but even more. I didn't have space, I should have added. So it's important for us to keep that in mind. If you look at the gastrointestinal motility, it plays a part. Because if you have cyclical vomiting, one of the things you find in people who use cannabinoids, it's a problem. But at the same time, it's good for chemotherapy-induced nausea. They have cannabis and they have a good appetite. We also know it affects olfactory, gustatory functions as well. So when you look at dementia obviously is this vast ocean. There's so much that one can say about dementia. It's sometimes scary. And as human beings, we often like to do one small little thing and claim, this is it. So when dopamine came out, oh my God, it was dopamine. When adrenaline, noradrenaline, this is what drives everything, right? Until we realize, hang on a sec, there's a problem here. It's not working. So when you look at the way we conceptualize dementia, we know that now there are certain things that modify dementia, the course of dementia. What are these things? Amyloid beta. Then you have the tau protein. You have neuroinflammation. Then you have the neuroprotective agents. You have PDE4. You have lots of different disease-modifying agents available that are supposed to tackle the etiology, okay? Now, if you look at the etiology, the causes of dementia, we talk about the amyloid deposits in the brain. So there's an abnormality. There's the amyloid precursor protein that is cleaved. You have the alpha protease enzyme that cleaves it. It breaks it in a manner in which it is not actually soluble. It builds up in the brain. It causes dementia. It's very simplistic. Now, when you look at mechanisms of actions of the medications we give Aricept, or donepezil, galantamine, rivastigmine. These three are cholinesterase inhibitors. So all it basically does is increase the amount of acetylcholine. And yet there are so many more things, as you can see in disease modifying, that the first that we spoke about is beta, amyloid beta. But then you have the tau proteins. Tau proteins maintain these microtubules that maintain the cell structure. So when we get older and the cell structure is not very good and weak, these cells die, apoptosis. We know these cells don't survive. So when you have the amyloid beta proteins building and you have the tau protein building in and their acetylcholine levels going in, and then you have neuroinflammation, and yet the psychiatrist treating dementia or the physician treating dementia gives you a cholinesterase inhibitor, it's tackling only one part of the problem. Now that is an issue, because if you have arthritis and you've broken the bone, and all I'm going to do there is give you anti-inflammatories, your bone is not going to heal. You need to have a plaster, you need to give painkillers, and you need to give something for arthritis. You have to, you don't have an option. But yet our treatment for dementia is so basic. So we have to really understand that the causation of dementia is so varied that our interventions also have to keep those things in mind. What about links to pain? This study was done in 2019, the Einstein aging study, which is fascinating because it shows higher levels of pain were correlated with higher possibility of dementia. This is a very interesting study by Ikram, but it's important for us to realize that when older people come to you complaining of pain, please do a memory assessment. That's the least we can do. Ask the family about finances, capacity, because we know there's a lot of elder abuse. We know there's lots of people selling all these kinds of weird things and changing your gas heater. They're vulnerable. You know, I'm not saying that we should police society, but as clinicians, when they come to us, we have a duty to make sure that the memory is okay. We need to at least do a memory test. We also know the dysfunction of the locus coeruleus, norepinephrine system, was connected to chronic pain. So this is very, very important because we have gone from this notion of let's classify it based on symptoms, you know. So Mrs. Jane forgot to take her wallet from home. She's gone to the bank. She's forgotten a passcode. You know, I think she has dementia. Well, actually, no. Mrs. Jane had bought a new house. She had parked in a new place. She had to go to a new bank. And she normally writes down her passcode and she's left that in the bag. So she doesn't have dementia, actually. Oh, no, I think it's different. You see, we have no way of clarifying it. We're basing it purely on hearsay, history. So what has happened over the last few years has been a shift, a seismic shift into the proteinopathic neurodegeneration. I know it's a bit full. I'm going to explain this to you. I'm just going to put this on so that I can kind of get a feel for people who are probably getting confused or not. Sorry, it takes a lot of space. Okay, so we'll start at the bottom, okay? So we initially started classifying diseases based on symptom groups, symptom subgroups, clusters of symptoms. And we put this all together and said, you know what, this is most likely to be this is most likely to be this. So we looked at neurodegenerative diseases from the 1900s, and we knew there was a condition called Alzheimer's, FTD, Parkinson's, Parkinsonism. We knew there were all these different variants, all based on symptom subtypes. Then we went into the clinical phenotypes, a bit more specific, multisystem atrophy, progressive supranuclear nuclear palsy, Parkinson's disease, Lewy body disease. We started breaking it down in different ways in which we would have much more clarity in terms of how we would actually address these issues. So for example, somebody has late onset Alzheimer's dementia, early onset Alzheimer's dementia. You know, now we know there's a very aggressive form of Alzheimer's dementia that starts at the age of 45. We know that alcohol plays a big part. We know that when there's aggression, increase in GABA levels. GABA is what the benzodiazepines act on. They actually increase aggression. But when an elderly individual who has dementia goes to see the doctor and the patient is not sleeping well, what are they prescribed? Benzodiazepines or trazodone, or they're giving a very short-acting benzodiazepines. The issue here is if it increases GABA and there's likelihood of aggression, why are we giving it to them? What is it that we're looking for here? So when you look at the importance of classificatory systems, it has to be based on etiology. So look at how things have evolved as we go up. Then we looked into molecular pathology. We realized there's a group of these symptom clusters that are caused by certain accumulations in the brain. What are these accumulations? It can be alpha-synuclein. So for example, when you talk of Parkinson's disease, Lewy body disease, PSP, multisystem atrophy, we see that these are because of the accumulation of a particular proteinopathy, and this is called alpha-synuclein. Then there's the amyloid beta 42, right? So you look at the tau protein. Now you look at these various breakdowns that I've showed you in the slide. We are shifting from what used to be a symptom cluster to a clinical phenotype specifically to a proteinopathy, and now we are looking at biomarkers. So now you'll see in the news now and then people saying we can detect Alzheimer's 10 years earlier before the clinical manifestation, because by the time we diagnose, there's already 30 to 50% damage in the brain. So it's kind of late by the time we pick it up. So the symptom subgroup clustering is not working. We have to go beyond that. Otherwise, we are losing the battle to protect people's memories and keep them going longer, because that's what we want to do. We want people to be functional within the larger scheme of their ability to maintain their finances, interact with the loved ones, maintain their memories. We need to be able to do that. So when we look at symptom subclusters, we know there are certain things that we could do in terms of identifying biomarkers. The problem is we are still struggling to identify specific biomarkers. Some of these biomarkers may be biomarkers of other disorders as well. So we still be getting there, but we still have a long way to go. If you look, for example, at the genes, ApoE4, okay, I'm just going to take one of them. You take ApoE4. Now, most of us know if you have E4, E2, there are variations in terms of what your risk is. So we do have that knowledge base, but how much of it do we use in clinical practice? The excuse often is, well, it's expensive, we can't get the test done. Which is more expensive, having a society that has 50 million people with dementia and increasing with the prevalence of going to be 68%, versus investing right now and getting these people to be more productive so that there is actually better ability to sustain the economy. Because if you don't have a healthy population, you don't have a healthy economy. You don't have a healthy economy, you don't have a healthy country. So we have to start rethinking how we address these issues when patients walk through that door. We need to be thinking differently. I'm not saying throw away DSM-5. We still need the DSM-5. We still need symptom clusters because that's all we have. But if you're going to start looking at things differently, we need to understand things like, what is FUS? What exactly does FUS mean? What does fused in sarcoma protein mean? What is it that we are talking about here? We need to understand what is ubiquitin proteasome system, okay? So I spoke about alpha-synuclein, amyloid beta 42, tau proteins. We spoke about FUS, the sarcoma protein. Now we're talking about ubiquitin. So if you imagine the city, a cell to be a city, ubiquitin is like the police officers. They go there, they catch all the bad stuff. So the ubiquitin is what really leads on to the process of eliminating harmful things and things like that. It's a very important system. It's called the ubiquitin proteasome system. We can have a separate lecture just on that, and it's fascinating. But it's important for us to also know that we have to access certain centers of excellence to be able to do it. So I'm not sure if they do some of this in Ottawa, but we need to be looking more at this. And the reason we need to be doing this is if Canada is going to be a global leader, and I'm really hoping we can pitch Canada, deliver knowledge to all walks of life in terms of how we need to understand dementia, but collect more and better, more robust data for research, we will lose the battle. And I'm telling you right now, there are so many people across the globe, so many countries aggressively doing research in this area, and we are way behind. So when I started using cannabinoids in 2008, and I'd mentioned this to a few colleagues, many people dismissed this because they didn't know about it, and they just felt it's some kind of it's not very important. Now we are seeing more and more of the role of cannabinoids, because cannabinoids don't just do symptom control. Cannabinoids actually have a very interesting mechanism of action. My apologies for this very, very complicated slide, but I'll explain it to you and make it easy for you. When we talk about the endocannabinoid system, we talk about a plethora of actions that this particular molecule has on the body system. So you have anandamide receptors, and you have 2-acylglycerol, 2-AG, right? Now, they all have different things that they do in the body. But it's very important to realize that when you talk about accumulation of cells, things like the microglia, which go into which are there, they engulf bacteria, they engulf things that are harmful, macrophages. These are all for protecting the body, you immediately start thinking, well, there's a ubiquitin system as well. So when I give somebody Aricept, I'm really not doing any of this. All I'm doing is increasing the amount of acetylcholine. That is really, really sad, because if you look at the extent of involvement of the causative agents of dementia, it's huge. But what we are doing is increasing one chemical in the brain, and we find a 30% response. With cannabinoids, and if you want to pull out my paper, it was published in 2013. If you put Amanullah and cannabinoids in dementia, you will see it. And I wrote in a textbook for Professor Preedy in King's College in London, and it's probably one of the most authoritative books on dementia, which is cannabis. It's a massive book, but it contains everything about cannabinoids that one would want to know, the different systems involved, dementias, Parkinson's, inflammatory conditions, you name it. What this particular molecule does, interestingly, cannabinoids do affect the acetylcholine levels. They do affect tau protein. They affect amyloid buildup. They also have an effect on NMDA. So all of a sudden you have a molecule that seems to have a role for preventing and protecting the brain from these areas. Now, the sample I studied were not patients with early dementia. They were not people who presented walking through the door saying, I'm forgetful, and I gave them cannabinoids. They weren't. These were people with the single most expensive part of the dementia management, which was basically BPSD. They were agitated, irritable, and the medications we would give them was risperidone. We would give them haloperidol, quetiapine, aripiprazole more recently. So I'm not saying we don't have a role for them. All I'm saying is what we were giving them was not addressing the cause of the problem. So my interest in autism and ADHD came up because this was missed in the elderly. And there was a case report that came up many years ago about how they found methylphenidate to be very effective in a patient with frontotemporal dementia. What they didn't take into account was the patient actually had ADHD. Cannabinoids we know now, and which is why a lot of kids use cannabis who have ADHD. It does have an effect on ADHD. It helps calm them down. So the potential role of cannabinoids in people with BPSD and dementia could be, number one, that these are people who may have underlying ADHD. Number two, this may be a group of people who have more pain symptoms. We know it's effective in pain. Maybe that's the reason they're better. Maybe that's why they're not so agitated. Maybe that's why they can sit calmer without really trying to gouge the eyes of the nurses out or scratch them or bite them or hit the doctor. We don't know. But if it is going to work and it's not going to make them rigid and stiff and give them risk of stroke, why not use it? And this is what fascinated me. So I started using this, and the family was so impressed. His wife insisted, when I was going to do this presentation internationally, that I put their picture on the background of my poster. And I did that, and she was thrilled. But the point is, we often forget in life that sometimes we need to think out of the box, because thinking in the box never, ever made scientific progress. It is important for us to be creative, but more importantly, inquisitive. There are right now 2 or 3 of the molecules I'm looking at for the role in dementia, because we need to be thinking outside the box. It should be safe. These are medications that should have been looked at in terms of trials, phase 1, phase 2, so that we know it's not going to hurt anybody. But at the same time, we need to look at whether we can repurpose medications for different indications. Very, very important. So why I put this diagram up here is just to show you that when we think of cannabis, it's not the guy standing by the street corner smoking weed and who is high. We are talking about the potential therapeutic role of a molecule that we know we can synthesize in the lab. So every patient that had been put on cannabinoids has all been synthetic cannabinoids. I do not tell my elderly patients to please go down and get a joint and smoke it in the evening and it calms your BPSD, or tell the staff to give it to the patient. Nothing like that. But I use synthetic cannabinoids, that's Avalon. And the effects have been stunning. Recently, they did a randomized controlled trial in Sunnybrook, and the findings were very positive. So the point is, if we have a molecule that potentially could help cut down in terms of the risks because that BPSD can give them a better quality of life, reduce their agitation. They can sleep better. They can eat better. They're not biting or scratching or hitting. And then we know that they're able to actually engage in interactions because they're not as anxious. What's stopping us from using it? Nothing. I apologize. We've gone from crowded to almost like the traffic, in Toronto. My apologies. But I'll make it simple for you. So we have receptor systems, CB1, CB2. We have anandamide receptors. What do? They all have different actions. So for example, CB1 receptors, look at the inflammatory response from the tumor necrosis factor, cell migration, interleukin-6. They all have a role in being anti-inflammatories. The endocannabinoid systems, the moment there's tissue injury, there's endocannabinoids that's activated. We often don't think about it because our understanding of the opiate system somehow has become the major theme. And now we are shifting focus to recognize that it's not just the opiate system, endogenous opiate system, there is the endogenous cannabinoid system as well. Look at the complications from diabetes, peripheral neuropathy, cardiomyopathy, neuropathy. We know there's lots of complications that rise from it, but again, there's endothelial injury. So if CB1 activation can lead on to mitochondrial stimulation in terms of protective factors, reducing inflammation, then maybe there's a significant role, and we need to think the way we need to change the way we think. Okay. This was the one that with Ferrer in Spain. I'd used this model when I was we wrote the chapter for the book in London. So I spoke to you about so many different things, and this is kind of a summary. Okay. So we're talking about a synthetic cannabinoid. It reduces neuroinflammation, less excitotoxicity, decreased calcium influx, decreased acetylcholinesterase activity, which means more acetylcholine, what the Aricept and the donipazoles of the world, the rivastigmines do. Also, there's the tau protein. I told you the tau proteins that maintain the cell structure, the microtubules. It reduces phosphorylation, right? It reduces the enzymes that break it down, so tau proteins are more robust. It causes vasodilatation, so where there's a narrowing of the vessels and less blood supply, it opens it up. It reduces inflammation. I showed you the interleukins and things like that. It reduces the cytokine response. It reduces microglial reactivity. So look at the amyloid protein. It reduces neurotoxicity. It increases clearance. The key issue here, though, is in animal models, there's a time that you have to choose to use it. If you give it too early, it does not clear the amyloid proteins as much, so there's a buildup. If you use it too late, there's already a buildup. We still don't know what that critical phase is, and I've been doing this for the last 10 years, trying to figure out which is the critical phase. We need to start using it to prevent BPSD. I still have a long way to go. It also reduces apoptosis, and it increases neurogenesis. It increases neurotrophin, increases autophagy, which is getting rid of the myeloid proteins. So this, in a nutshell, kind of summarizes what potentially Nabalon can do. Okay. Now, what's the difference between street cannabis and medical cannabis? Very simple. With street cannabis, we have no idea what goes into it. We really don't. We know that it's become far more potent. So the breakdown products of cannabis on the street is almost 300 to 400 breakdown products, some of which are very toxic. The medicinal one, we know it's cultivated in a specific way, but we still have a long way to go. So I stick to the synthetic version because I feel safer and I don't want to endanger any of my patients. So what can we do to target specific connectomes in the brain to achieve a desirable goal? The first is to make it patient-specific, which is why when you take a history, take a good history, a very good history. A good clinician takes a good history. Always take family history. Look at what it is that is there in the profile. 3-4 generations behind. Look at it. Try and look into movement disorders, schizophrenia, psychosis. Look into mood disorders. What age did dementia start? What age did depression start? What age did they start becoming more confused without the necessary diagnosis of dementia? Take that history. Look at drug specificities. What do you think they would respond to, not respond to? There's also newer areas, pharmacogenomics. It's coming in. We still are nowhere there. We still give medications, try it before we test the cytochrome system. We should be doing it the other way around. Test the cytochrome system and then choose the medication they need. We still have ways to go before we understand the implications for that. We also need to know how an individual's genotype could affect, sorry, their response to therapy, as well as how genetic polymorphisms can affect the breakdown of these products. Very important for us to know these things, because some people may need higher amounts, some people may need lower amounts, some people may respond in a manner in which you would never have foreseen it. There's also variance with the cytochrome, and they may affect the way THC is metabolized. So some people may be more predisposed if the THC content is high for psychosis and things. So we have to keep that in mind. We always have to be cautious, have a high index of suspicion. Many patients carry genetic variants that may predispose them for the development of psychosis, memory impairment. Identification will help identify, it will improve patient safety and empower individuals. And if it will not, the key thing is we may never really completely eliminate risk, but at least we can minimize it. With that, I've come to the end of my presentation. We have enough time for questions, and I'm happy to take questions.
Thank you so much, Dr. Amanullah. That was a wonderful presentation. We do have one question in the chat box right now. It is, what is the title and author of the book from London?
It's by Professor Preedy, and it's called Cannabis and Related Pathologies. And its related pathologies.
Perfect. Thank you.
Oh, there's a question from Lara about the dosing of Nabalon. Nabalon comes as 0.5 milligrams. The 0.25, many provinces don't cover it, so it comes as 0.5. I have often started at 0.5, depending on the levels of agitation. So we had a patient with frontotemporal dementia when I was working in PEI. Lovely man, he was a pastor. He used to go preaching. So he'd take the Bible and he'd go around the corridor telling everybody about the Bible, and many patients would get angry with him. They would get irritated with him, but he would still keep doing it. So it led on to confrontations with patients. I put him on 0.5 in the afternoon. It did work. He was much calmer. And then I bumped it up to 0.5 BID. He had no problems. We had another guy with early onset dementia, rapidly progressive, very, very agitated. He would literally rip the arms off the Broda chair, and Broda chairs are built very strong. For those of you who've actually tried holding them, very, very strong, well constructed. And he literally ripped the arms off. So he needed we started at 0.5 in the morning because we wanted his cares to be taken care of. And then it went up to 0.5 TID. And 1 milligram TID, and he did very well with the Nabalon. There were a whole series of patients like that who've done well. There's another gentleman who would always be naked because during his prime they would go to nudist colonies and things like that. And we put him on 1 milligram BID to start because it was getting very disruptive on the unit in the hospital, and people just could not handle him. My family had given up. I started him in 1 BID. We discharged him home. Family are happy to have him home.
Just put up on the screen if anyone needs a reminder on how to ask a question that's a visual for you. We'll just take another minute to see if some more questions come in.
I'm sorry, I can't find my hand up symbol. It's Lara again.
That's okay. Go ahead, Lara.
So when you're having a person with BPSD and they're already on risperidone and maybe you've tried other antipsychotics and nothing's really helping, do you wean them off and then wean them onto the Nabalone, or do you use both at the same time?
Excellent.
And is Nabalone the primary medication that you're using?
Yeah, wonderful question. So you should pull out my paper of 2014. Just put my name, put Cannabinoids and Dementia. What we found there is it cuts down the total amount of antipsychotics that you need. There's a cohort of patients who will need a very small dose, 0.125 milligrams of risperidone along with this. So for example, if you have a patient on risperidone, 0.5 BID, quetiapine, 50 milligrams at bedtime, PRN haloperidol, you add the Nabalon onto this, and then you reduce the dose of the PRN medications, number one. The first is the PRN medications because it gets abused in a lot of homes. I find nurses will come in and they've done the night shift. The come in, patient is really agitated. They sedate the patient. Evening staff come in, patient has just woken up, getting agitated. They can't do their work. Patient is sedated again. So they'll come and tell me, Dr. A, please do something. The patient is really agitated. You take the history. Actually, the patient is not agitated. Patient is getting out of sleep and he's restless. So they understand it from that point of view, but it doesn't make it easier for the nursing staff. So I always tell them, once we start the patient on Nabalon, you're going to have to make a concerted effort not to use PRN medications because the patient will take time for the sleep-wake cycle to normalize. We cannot force them to fit our own hospital timings. So they usually do, and it's very important because if you don't cut down the use of PRNs, you'll never be able to assess the effectiveness of Nabalon. Once you start it on a regular basis, 0.5 BID, TID, then you can reduce the dose of risperidone. Can you eliminate it completely? Yeah, you can. But do you have to use it combined? In frontotemporal dementia, I find that I have always had to use a bit of the risperidone, 0.125. Patients with early onset Alzheimer's dementia have had to use risperidone, trazodone at bedtime because they don't sleep very well. Patients who have Parkinson's Lewy body, many of them require quetiapine at lower doses, so 6.25 BID, and you can add the Nabalon onto that, and it works very, very well. So going back to your question, do you need to wean off? Ideally, yes. If the patient is on other antipsychotics and you feel that you will add Nabalon, good dose, good response, then you start weaning off with the other antipsychotics. You may need to keep a low dose. Don't be disillusioned, because the key thing is to minimize the use of antipsychotics and maximize the quality of life. There's one from Mark. So many of our patients take trazodone for sleep as GPs. Okay. Now, Zopiclone is not safe in the elderly. There was a study done looking at the sway test and also in non-dementia patients who drive. The number of accidents involving Zopiclone is very high. What it does is they did a study looking at the deviation from the midline, and people on Zopiclone are more likely to do that. On Zopiclone, you wake up at night, you fail the sway test, so you're more likely to fall. For this group of people, you may want to try, there's a new lemborexin that has come out, which is not supposed to cause that degree of swaying. I've used it in a few elderly, fairly good effect. Can you use CBD oil? Absolutely. But what would be better is melatonin. The problem with our understanding of melatonin is that we tend to use very, very small doses. 3 milligrams, 5 milligrams. We need to be more aggressive, because if they don't sleep well, you have a problem. We know that people who don't sleep well, you have a bigger buildup of amyloid. They say that people who sleep flat on the stomach, the endolymphatic, there's a problem in that the amyloid is not cleared properly. So there are so many variations in terms of how we approach people with sleep issues, but the key thing is to educate them. I often tell older patients, your sleep quality is not going to be as good. I can give you medications, but it's not going to help you in the long run. Zopiclone can affect your memory, can make you fall. Would you rather take that risk? They'll say no. I say, well, go to bed a bit later, use melatonin. If you want to have a warm glass of milk, have a banana, because they're both rich in tryptophan, and it gets converted to serotonin and melatonin. You may want to try pistachios, avocado, turkey. Turkey is very good for sleep, but you can't eat it every night. You can maybe have it occasionally. But the key thing is to look at alternatives that can help with the sleep-wake cycle as well. Maybe a bit of exercising, go for a walk, do something to calm yourself down, listen to some music, put white noise in the background. When you do all these things in combination, you find that the specific focus on sleep goes away, because most people worry about sleeping that night because they haven't slept the previous 2 nights. And the more you think about sleeping, you're not going to sleep. So cognitive behavior therapy. So for this group of people, trazodone really doesn't do very much. It really is not a great medication of sleep. Zopiclone messes the REM sleep. It causes rebound, worsening of insomnia. The new orexin antagonists may have a more promising role that may be worth looking at as well. Nabalon definitely calms people down. You can even use it at night. And I've had patients who've slept well on it. They eat better. They feel better, full stomach, less agitated. They sleep better. Does that answer your question?
We have another question from Jennifer Coop. When using cannabis with your patients, have you seen an impact on appetite, and have you noticed any negative side effects such as delirium?
Okay, the appetite actually goes up. They actually enjoy their meals. They do eat more. In terms of negative effect, when I moved to Woodstock, one of the first patients we gave Nabalon to, there was an episode of a seizure. I went back and looked into it. It wasn't Nabalon. The patient was on benzodiazepines that were tapered off very quickly. It had nothing to do with the Nabalon. We didn't know that history. But I have never had a patient with a bad effect of Nabalon till today. I have never. Maybe some patients don't respond as well, but I've never had a bad adverse kind of reaction to it. The new sleep medication is lemborexant. It's also called Dayvigo. I've used it in a few patients, but it's still early days, and I would advise you to use it cautiously, because the last thing we want is to go by marketing techniques, and we want to make sure that we give our patients safe medications. But it's not. It is compared to Zopiclone. It's in the tests they did called the Sunrise 1 and Sunrise 2 study. They apparently found that it doesn't cause as much sway when you wake up at night. It doesn't affect driving the way that Zopiclone does. But you obviously have to keep in perspective. It's called Dayvigo. Yeah.
There's also a question from Dr. Anna Bashesky. What is the expected time for Nabalone to work for restlessness/agitation? She might have missed this info, and she apologizes if so.
Oh, no, please don't apologize. We're all here to learn. It works very quickly, and that's the beauty of Nabalon. I've had family members who literally want to come and give you a hug because they can take the loved ones back home. And for me, the key thing is to get them back home, because the system is really crumbling. And the vested interest is we want them to do well. We want the hospital to do well, but we want the system to be sustainable. And right now, I'm sure it's the same thing in Ottawa. We don't have enough old age homes. We don't have enough long-term care facilities. If people can be made to be more functional, families don't feel scared, let them take them home. So use the Nabalon, and it works very quickly. I've seen effects within 24 hours with Nabalon. Oh, families. Well, I'll tell you an interesting story. I had a very evangelical couple who came in. So they heard my name, Amanullah. She said, "Do you use weed?" I said, "No, I've never used weed." "So why are you recommending it?" I said, "Well, it's a synthetic version. And, they've used it for pain for centuries. They've used it in chemotherapy as well." "Well, he doesn't have cancer." I said, "I know he doesn't have cancer, but I've used it in these patients. You don't have to take it. I can give you risperidone. It's available, but it can increase the risk of stroke." She said, "Well, I don't know. We've never used drugs in our life. I have my reservations about it." I said, "Look, I can give you the other one. Absolutely. I don't have a problem with it. But if this has research evidence saying that we do not cause strokes, unlike the warning that we have with antipsychotics, wouldn't you err on the side of caution? I mean, if it's not good, I'll stop it. I don't get a commission from this, from those who make Nabalon." She was very reluctant, and she said, "Okay, we'll give it a try." And she gave it, and she said, "You know what, doctor, it works really well. Maybe we should have done this a long time back." So yes, it's very interesting. Sometimes it's comical, actually, but obviously you can't laugh, right? You don't want people to feel bad, but inside you're chuckling to yourself, thinking, I would have asked the same question.
These were great questions. It was a great discussion. Dr. Amanullah, thank you so much for your presentation and your knowledge that you shared with us today, so that we can go back and share it in our area and with our patients.
Wonderful. Thank you for inviting me.
We just wanted to make note that we have a couple of upcoming events. Our Regional Geriatric Showcase is on Friday. This is a free event where we will have speakers Kelly Kay and Adam Morrison from the Provincial Geriatrics Leadership Office speaking on evolving to meet the changing needs of older adults. We will also have 5 award presentations for geriatric service excellence in our region, and an opportunity to do a meet and greet if people so desire with the directors of the RGPEO and of the PGLO. Our geriatric education series, our 2-day virtual event on the core introduction to geriatrics, will be on November 22nd and 23rd. And all of this information is available on our website should you wish to register. Thank you all again for coming. And thank you again, Dr. Amanullah, for a wonderful presentation. We appreciate you taking the time out of your very busy schedule.